Welcome, everyone, to another special episode of Arthritis Consumer Experts #CR Arthritis series from the Canadian Rheumatology Association's annual scientific meeting this year in Calgary. Today, I'm really happy and excited that we're going to be joined by Dr. Sasha Bernatsky, a rheumatologist, a James McGill professor, and a senior scientist at the Research Institute of the McGill University Health Centre, and a really good friend of ACE's. Dr. Bernatsky is known internationally for her work on drug safety and effectiveness. Dr. Bernatsky, welcome back to our show.
Thank you so much. It's great talking to you.
You're presenting a research abstract poster on the link between air pollution and the development of systemic autoimmune rheumatic diseases. We have talked to you in the past about this subject. We look forward to learning more today. Can you tell us what some of the key findings are from your poster and how significant is this risk?
Sure. So this will be a poster tour on Friday from 12 to 12:30. And this is one of a series of papers that we've been publishing on air pollution and rheumatic diseases. So I always start by saying air pollution is very complex, and this is true, and that's why it's a challenge to study it, but it's an interesting challenge. And one of the reasons why air pollution is an interesting risk factor to study in terms of disease risk in rheumatology is if you look at the autoimmune rheumatic diseases, we really haven't gotten a handle yet on what causes these conditions. So what causes systemic lupus? Well, we know that there's some genetic factors, but they're a little bit poorly categorized, and seems like as well as genetic factors, you need some environmental insults. But those are also hard to get a handle on. And if there's a few occupational risk factors that individuals have looked at, but they don't seem to explain the majority of the risk of systemic autoimmune rheumatic disease. So this is the rationale for looking at air pollution, which we're all exposed to. So the current analysis was done with administrative health data from Quebec. So that's each province has particular diagnostic codes within their administrative health data that identify if a physician saw a patient that they diagnosed with the systemic autoimmune rheumatic disease, and also if the person was hospitalized and had that diagnosis attributed to them, we have that information as well. So we can start with this is what we did in Quebec. So start with all the individuals. And our time period started in 2000. So you can find all the individuals in Quebec, all the adults who didn't have a systemic autoimmune rheumatic disease, and then follow them over time. And we followed up to the end of 2019. So we were able to work with the holders of the administrative health data to assign exposures related to air pollution. And one of the most interesting air pollution exposures is called PM2.5, or fine particulate matter. So this, you can break down air pollution exposure into the different components, including this, and you can even break down PM2.5 further into its components. So there's groups in Canada that compile all that kind of exposure information for every postal code area in Canada. And so you can obtain that data, the baseline exposures for air pollution over time for every postal code. So we took the Quebec exposures, and we asked the data holders for the administrative health data to match them to people in our cohort. We can't, the administrative data holders in Quebec don't allow you to have the 6-digit postal codes, but they will create the exposure for you. So we can't see the postal codes, they can. Then they gave us the data to analyze that included these exposures. So what we found was there was some association between fine particulate matter and outcomes, including systemic autoimmune rheumatic diseases. So this is actually consistent with other data that we've been generating. And so we've looked at other jurisdictions. So we've looked so we started to look at Ontario data as well and finding the same sort of associations. And we looked at the presence. We're working with a group of Canadian investigators, including the methodologic experts in environmental health and air pollution, and May Choi and Dr. Fritzler in Calgary on some serum samples from CanPath. It's a general population cohort. So we're looking at correlations between air pollution and autoantibodies, and we're finding some very interesting results there as well. So yeah, go ahead.
Just a quick question for our listeners and viewers. When you are talking about systemic autoimmune rheumatic diseases, you've mentioned lupus. What other diseases are you talking about?
Sure. So when you're working with administrative health data, in some of that, we're using international classification of diseases, and in some provincial data sets, like in Ontario, you're looking at diagnostic codes that fall under a certain category that includes systemic lupus, kind of grouped together. So systemic lupus, which is probably the most common, or Sjogren's, which is also relatively common. And that group also includes Sjogren's, so systemic lupus, Sjogren's, scleroderma, dermatomyositis, and polymyositis, and undifferentiated connective tissue diseases. So when we talk about SARDs or systemic autoimmune rheumatic diseases, with administrative health data, that's the group that I'm talking about. So a certain percentage will be systemic lupus, but there'll be those other conditions as well.
And so the person living with lupus or these other SARS diseases, what should they be aware of when it comes to the effect of air pollution exposure on disease onset or even progression?
Right. So if you already have lupus, it's interesting information, because I think a lot of people wonder, why did I get lupus? I can't answer that for my patients. It's rare that there's even like a family history of lupus. So we explain like we don't really know, we tell the whole story, but if you've already developed systemic lupus, say, I think this information is part of the story that helps all of us, lupus or not, think about how we can protect our health. So there are some data suggesting that air pollution can also, even if you've already had lupus, it can possibly trigger more active lupus. So we did years ago look at that and found in our lupus cohort that there was air pollution could, and it was fine particulate matter that we were mainly focused on, could seem to be associated with some renal activity indicators and some autoantibodies. So that suggests that air pollution can perhaps worsen disease activity. And it makes sense, because this fine particulate matter that we're talking about, when you breathe it in, it gets into our bloodstreams and it can cause inflammation. So it's, to me, it makes sense. So what can we do? Well, there's air quality indicators. So there's an air quality index that many countries have. So you can search Canada Air Quality Index and find the air quality indicator for you where you live. And that the websites currently give suggestions depending on your vulnerability. So they tend to focus on things like asthma, which we would suspect could be triggered by air pollution, but they don't necessarily have the whole they haven't necessarily included things like systemic lupus, because they're just starting to learn about those data. So if you go to the air quality index and the air quality is not great, the suggestions for people who are vulnerable, and if you want to to be cautious, you could say, I'll go with the I'll consider myself vulnerable and see what the suggestions are based on the air quality of that day. So I think we have to be a little bit, we have to think though about like, what does that really mean on a day-to-day basis? Because some of the suggestions are, if the air quality is bad, stay indoors. But you have to make sure that your air quality indoors is good too. So if you have a fireplace, that's gonna worsen your air quality. So you have to also make some like sort of informed considerations about your air quality there. And then the another thing is, if you don't have air conditioner and the air quality is really bad, you're going to be opening your windows. So we can be at risk, but sometimes there's a limited amount of actions that we can do. I think particularly for somebody who has less economic resources. So I think we have to consider that. I think one thing we shouldn't do is panic. So we are fortunate that air quality is pretty good in North America in general. We do have, we if you remember in 2023, how bad the air quality was some days in the summer when we had a lot of air, but we had a lot of forest fires in Quebec. In Montreal, it was quite noticeable. So we do have those factors impacting our air quality. But I'll say a couple other things here. So one is, if you smoke, worrying about air quality is a little bit, of less consequences. So I would say definitely make sure that the other things you can control are optimized for your health and to prevent, overactive disease, because smoking is, if you do have systemic lupus, is going to be bad for your outcomes. It's going to, make some of your drugs work less well. It can, possibly, it could definitely actually contribute to, comorbid conditions. So those are some of the considerations that I guess when you were thinking about air pollution and our health.
Thank you.
Again,
Go ahead.
No, I was just going to say, another thing you can do, of course, is just like each do our part to contribute to good air quality. So try not to, walk if you, instead of taking car, all these things that decrease, that can help improve our air quality and from the point of view of a consumer.
Yeah, you mentioned wildfires. As you know, ACE is based in Vancouver, and we've just now, come to expect that every summer we're going to have compromised air quality, and those fine particulate matters are going to be out there. I think what's interesting is it's because it's such early days and the science right now is just being collected. We don't really know what that impact of these wildfires are, but I think you've identified, obviously, it's a potential risk, and we need to act accordingly.
Yeah, I don't know if you've noticed it, the wildfire season's starting earlier and
absolutely
longer. So last year we did get some CHR funding to extend these studies and look specifically at air pollution related to wildfire.
We're going to have links to the poster and some of the other work that you've done in this area at the end of the episode. So if people are interested, we're going to be able to provide them some resources. Dr. Bernatsky, let's move on to the second topic. You're not necessarily presenting this at the CRA annual meeting, but it is something you're going to be talking to people about in the corridors, because it's something that you are increasingly getting involved in, and that's around hydroxychloroquine retinal monitoring in Canada. Would like to ask you just a few questions about this issue. Maybe to start, why is regular retinal screening so important for people taking hydroxychloroquine, and what are the risks if this monitoring is not done?
Sure. So I'm a bit obsessed with hydroxychloroquine, which is the main anti-malarial therapy that we use. I guess in general, I'm obsessed with antimalarials because a lot of my patients do have lupus. So it's a real cornerstone therapy, and the treatment guidelines emphasize that. You may need other medications, but the hydroxychloroquine is kind of the core a treatment. And if you're diagnosed with lupus in your 20s, you'll be exposed to this drug potentially for many decades. You know, diagnosed in your 20s or earlier and you live to be 95, that's a long time that you're exposed to the medication. And this medication is like some medications like your thyroid supplement or vitamin B12, you take it and it flushes out of your system, so it doesn't build up. But hydroxychloroquine is one of those medications that builds up in our body. And one of the tissues that it can accumulate in is the back of your eye or the retina. So most patients will not have this side effect, but some patients, because of the buildup in the back of the eye, we call that retinal toxicity. And as soon as it's detected, we stop the therapy, and you really can't continue on that medication for the remainder of your life. This is the current understanding. So we've long understood that regular checks by an eye doctor can help us detect that early on. So way back 30 years ago, people on long-term hydroxychloroquine and related drugs would get such bad damage. It was so late that they would actually have visual deficits. Now we're seeing this much earlier, but there's a real difficulty in helping our patients get regular monitoring. So one of the things is just, it's hard to fit in visits with an ophthalmologist when you're somebody that has lupus, because you got a lot of other doctor visits and you've got your life to live and so on. But the recommendations of the American College of Rheumatology and the British Ophthalmology Association do focus on regular evaluations with something called optical coherence tomography, or OCT. So there is a little bit of so in the current guidelines by the ACR, which is a joint statement with the Derm Association and Ophthalmology in the US, they say get a baseline assessment when you start the drug, just to make sure there's nothing else going on. And then traditionally in our clinic, we do tend to encourage people to see their eye doctor yearly to make sure there's no other eye problems. But our ophthalmologists in Montreal, the ones that are at our hospital center, said we're really too busy to be doing regular monitoring, and the British guidelines for ophthalmology for monitoring indicate you don't need necessarily to be monitored in the first 5 years. So the first 5 years is probably not as critical, but we do feel in our clinic it's nice to develop that relationship with the ophthalmologist. But definitely the longer you take off hydroxychloroquine, the more important it becomes to be seen by an eye doctor regularly. And it's tricky because it can be when you're like 5-10 years out with your lupus, it can get to be a bit wearing, to have these constant doctor visits. And so, but it's very important for your eye health. And the guidelines are actually pretty focused on this OCT, using the OCT to detect early changes. It's a great test for detecting the earliest changes, which is thinning of the retina. And so, if you go, yes, go ahead.
So currently, my understanding is that patients in Canada must pay out of pocket for this test, the annual test. And, when you're talking about over decades of use, that can become a real significant financial burden. Why do you think it's not covered, and what barriers exist in getting it publicly funded for reimbursement?
Right. Well, Kelly, I'm hoping that maybe you can help me answer that. But yes, in talking to the other lupus specialists in Canada, it doesn't seem like there's any jurisdictions where patients on this drug can go to the ophthalmologist of their choosing and get this test done on a yearly basis in our own patients. And I've only realized this in the past year, is that patients do have to pay for this test, and a lot of them aren't getting it. It costs $200. And right, like every year, that's a lot of money. That's for a lot of patients. And 200, some of our patients are on disability or unemployed, and some of them have other, out-of-pocket medical costs. It seems like this is really something we should try to rectify. So I started some conversation with the CRA's Therapeutic Access Committee, and I think they're wonderful in what they do. People like Carter Thorne and Allison Kidd who care so much about getting access to our patients, for our patients, for the care that they need. So it remains to be seen how this is going to happen. I do think it might be something people want to tackle on a province by province level as well, because our healthcare decisions are made provincially. So one thing that, so there's different potential solutions to the problem, but maybe next year I'll have more of an update for how we're able to, whether and how we will be able to move that forward.
Yeah, and I think, as you identified, for our community to be effective at changing policy, our best chances, if not only arthritis health professionals and specialists like yourself get involved, but to do that alongside of patient and patient group organizations. So I'm confident that you and I will be talking about this in the not too distant future, and ACE looks forward to it.
I'm so grateful.
Of course, and that's a wrap for today's episode. Dr. Bernatsky, thank you so much for joining us today.
Thank you. So as we end, I just want to say that even if you don't get the OCT, please keep going to your eye doctor's visits, because there's other things that they can do, visual field and so forth. So thank you so much, Kelly.
Thank you. Good luck and have a great conference.
Thank you.
And thanks to everyone who is watching or listening to today's episode. We hope that you can join us again in our next episode of #CRArthritis, as ACE shares more exciting science from the CRA's annual scientific meeting. Goodbye for now.